Okay, so hello everybody. I just want to start off and prefacing this with apologies. Yesterday I did attempt to go live and there was some issues um, midstream, and so we ended up cutting it off and then we're scheduling it for today. So apologies for that and appreciate everybody tuning in to this live stream. So my name is Christopher Cutler. I'm the founder and executive director at the Heather Cutler Foundation. Um, We are a national nonprofit based in Newfoundland and Labrador, dedicated to improving the survival and overall quality of life for Canadians living with pancreatic cancer. This work is very personal to me. My mother was diagnosed with pancreatic cancer just over 3 years ago. She unfortunately passed away a little bit over a year ago. But sorry, our mission and our values are really built um, around her transition from being a registered nurse of 35 years into a patient, and just seeing some of the things that she experienced in the healthcare system, and particularly, of course, around pancreatic cancer and the landscape of what is the experience in Newfoundland and Labrador for people who do have pancreatic cancer, and not just Newfoundland and Labrador, the broader Atlantic Canada and Canada as a country. So I guess I'll just start out very quickly, just doing a quick um, announcement in terms of what we are announcing today, just for those who are tuning in and just want to understand what it is we're announcing and what we're doing. So today we are finally launching the first of our targeted patient grants. Um, a major barrier that is, of course, the Newfoundland and Labrador. We talk a lot about privilege in other areas, but especially when it relates to cancer care, privilege is definitely something that's evident. My mother was lucky enough to be able to have family connections that explore Johns Hopkins. She had a lot of opportunities that, definitely did play to her advantage during her treatment journey. However, we recognize that is not the case for everyone. Um, a lot of the times we look at our experience as a family going through the healthcare system and, with pancreatic cancer. And we did have a lot of opportunities, and that is not the case for everyone. In Newfoundland in particular, Newfoundland, Labrador, it's vast. A lot of people are having to travel from those rural communities into metro areas, especially St. John. That's our largest cancer center. So what we really wanted to do is start trying to alleviate a little bit of that issue with what we're able to and with our capacity as a nonprofit organization. So today I'll be talking about the release of those grants, the application process, and what we hope to accomplish with that. As well, then we'll just be touching base on our recent meeting with the Newfoundland government and going into a couple of particulars about that, what we talked about, and then as well what we hope to see in the future. So that's just what we'll be talking about really quickly today. So with that, I'm going to go into a little bit more detail just to let you know what's going on here. So I'm just going to start out with a couple statistics here. The 2024 projections for pancreatic cancer. So this year, around 7,100 will be diagnosed. Unfortunately, 6,100 of them will pass away. The five-year net survival for pancreatic cancer in Canada is around 10%. It has been that way for the past 35 years. There have been little to no tangible improvements for people living with pancreatic cancer. And that's something that we really have to try and move the needle on. Atlantic Canada in particular has some of the highest incidences of deaths from pancreatic cancer and some of the worst barriers when it comes to accessing what we believe should be the optimal treatment journey. In terms of clinical trials, we're looking at an overall 7% participation rate for Canadians throughout Canada in clinical trials. And when you look at Newfoundland and Labrador in particular, I think even 1% would be generous when we're talking about exclusively pancreatic cancer trials. If you do look at a historical offering of trials for people with pancreatic cancer in Newfoundland and Labrador, we are looking at something like 3 trials in the history of Newfoundland and Labrador. We have had 3 trials that have been offered to Canadians living with pancreatic cancer, Newfoundland and Labradorians living with pancreatic cancer. And this is a problem, right? Because if we look at every single medical treatment and you know, drug that we have available today, none of that was available through without going through the clinical trial process. So it's very, very important that people are participating in and have the opportunity to participate in clinical trials, because those trials are, what is going to lead to new treatments. And without new treatments, without new drugs, we can never improve the survival rate, right? So clinical trial access is a huge thing. It's very, very important. It cannot be understated. If we don't have clinical trial participation, then what are we doing? We're just waiting on we're waiting on the states to make discoveries and push those discoveries. We're waiting on studies that are happening in the mainland or happening elsewhere. So it's very alarming. It's very, very alarming to see that there are not clinical trials and we don't have Newfoundland and Labradorians participating in clinical trials. I know my mom in particular, when she was diagnosed, was told that if she wanted to participate in the clinical trials, she would have to move. Right? So that's the real patient experience here in Newfoundland and Labrador, is that you're being told, if you want to participate in clinical trials, you have to move. Of course, that's a problem because when we look at pancreatic cancer, we have 2 standards of care. Those are 2 chemotherapies. And other than that, there are approved immunotherapies. There are some options there, but those are highly dependent on both genetic and somatic testing. So just to touch base quickly on what those are, genetic testing is looking at the family history of pancreatic cancer, whereas we look at somatic. This is often called molecular profiling, biomarker testing. You'll hear a lot of terms for this, but essentially what this is doing is looking at the DNA of the cancer itself, right? Like looking for what they label as actionable mutations. They're called actionable because it means that with those specific mutations, patients are able to take part in trials that are studying their specific mutation and studying treatments that will target those mutations. What is the gold standard, really, right? So what should be happening? A large part of my mother's journey was hearing from advocacy organizations, whether that be Christ's Cause, whether that be Pancreatic Cancer Action Network in the States. There are an abundance of advocacy organizations. Obviously, they seek to bring the latest, best practices, the most up-to-date research to the general public. And that happens many times through these advocacy organizations. For example, the World Pancreatic Cancer Coalition. So that really serves as a go-to body that pushes, the evidence-based best practices and the kind of latest developments with pancreatic cancer and education around the disease to these advocacy organizations so that everybody can really be uniform. And then, of course, those advocacy organizations engage with the public. So as a member of the World Pancreatic Cancer Coalition, we really do have access to those resources and knowing what a treatment journey should look like for a patient. So what should be happening? Like, what should happen when somebody is diagnosed with pancreatic cancer? So what we would like to see and what we should be seeing is, as we're talking about genetic testing, They should be doing genetic testing, both genetic and somatic, so that's your molecular profiling from the beginning, right? Because where this is so important is that without these two tests, patients are not really able to make an informed decision about their treatment journey. Um, why is that? Because without these tests, of course, they're not going to know if they have specific mutations. They don't know if, for example, there are already drugs that are approved for them. For example, my mother, when she first had biomarker testing done, that identified a KRAS G12 G mutation that's very common among people with pancreatic cancer. I think it occurs in, I don't have the specific statistics with me right now, but I know that it's over 70%, I believe. So it's very common. As well, she did have a high, what's called a tumor mutational burden. So that was actually missed by the center in Canada. And then we rediscovered this a year later when the testing was redone by Johns Hopkins. And at that point, she was already she had a very low ECGO or a very low already chance of survival. She was very sick at this time. And then to pursue the treatment that she would have been eligible from day one, which was Keytruda, um, was not something that was feasible at this point. So yeah, you can only imagine like the difficulty to tell your mother when she's really out of options that, oh, we missed this one and this could have been an option. But after she'd been told that, oh yeah, there's this treatment, and then she was a very strong woman, and the doctor at that time, we were consulting with the doctor in Johns Hopkins in the States, and my mother was on FaceTime. Like, you could not tell that she was on her death, really, right? And so the doctor was really confident to move ahead with the treatment, but then when he followed up with our local oncologist, um, she had reiterated the fact that my mother was so sick and then we couldn't move through with our treatment. So these are the real kind of like implications of not having this testing done. If we're not doing this testing, then people are really missing out on making informed decisions, because if you don't know that you have specific mutations that, well, there's a drug for this, right? So you don't know that you can perhaps take this drug. You don't know that there's a clinical trial that's eligible to you. So if this is not happening, how can there be participation in clinical trials if not for, and the exception would that would be if a patient is looking to take part in a clinical trial that's not related to precision medicine. And again, precision medicine is just a simpler way to put that would be personalized medicine, right? So when you look at those mutations that your cancer has, you're really seeking more targeted therapies, right? And as well as experimental therapies or clinical trials. Um, this is really important because the last decade or so, we've really seen a transition in the cancer industry from these more systemic or whole body treatments, which are chemotherapies, into personalized therapies or therapies that are targeting specific mutations. And more so, you'll see plenty of trials now, especially for pancreatic cancer, that are looking to target specific mutations. I think we're seeing more of these just because pancreatic cancer has such a low survival rate. And there's a huge unmet need for patients to have therapies that are accessible. So to put that very simply, how the process looks and how it should look, when somebody is diagnosed, clinical trial discussions should take place from day one, right? We're a huge believer in that when you go for a diagnosis, you deserve to have all the information, you deserve to have the options, and then you need to make an informed decision. Without these tests taking place, then how can you be expected to really make an informed decision about your treatment journey, right? So it's very alarming. Molecular profiling, I know for my mother, and as well, from the initial focus groups that we've conducted, as well as surveys, one of the questions that we asked were, have you heard of genetic testing, or have you heard of molecular profiling or biomarker testing? Were you talked to about pancreatic enzymes? Were clinical trials a discussion? And almost all of their, yeah, pretty much all of the answers were, we weren't, or we didn't have conversations about clinical trials. I know specifically for my mother as well that clinical trials were viewed as something to pursue if the existing standard of care failed. Okay? So this is a problem. It's definitely a problem, and it's much larger than just conversations about clinical trials. The issue really in Newfoundland is even if we integrate, clinical trials and we have discussions about clinical trials, there are no clinical trials in Newfoundland and Labrador for people with pancreatic cancer. So, of course, we had advocacy organizations being like, enroll in clinical trials offer better outcomes, right? So naturally, for some people who have the ability to do so, and don't experience financial barriers, or they're okay with leaving where they are, this isn't an option for many people, obviously, because that's your support system, right? So asking a patient to leave their support system to pursue a clinical trial, especially, the cost incurred for that, even if, the trial site does, and in Canada, cover the cost of the treatments, you still have to think about other things like accommodation, and then this becomes inherently more complicated when you're looking at pursuing clinical trials in the States or outside of Canada. I think it's encouraging that we are seeing more clinical trials in Canada in general, especially when it relates to pancreatic cancer. But 2 years ago, when my mother wanted to pursue a clinical trials specific to her mutation were just beginning to pop up in America. And the decision was, do I leave here and go to Baltimore, or do I go somewhere else to be able to really get a chance and see if this treatment will work? Um, and that is a big decision for families to make. Um, Back to how it should look. Palliative care is a big thing. Um, Discussions about paramedics providing palliative care. That's an excellent program. We have in Newfoundland, and essentially what that does is take chemo patients out of having to go into emergency rooms and wait long, long hours, but rather, the paramedics will come to them in their home. And obviously, I can't say how much of a lifesaver that was for my mother as well. And what we're really seeing though is consistent application of that, and not everybody aware of that service. As well, things like nerve blocks, pancreatic enzymes, seeing now like early studies indicating really the value of pancreatic enzymes and just how much they can improve quality of life. And quality of life is a big thing for patients with pancreatic cancer as well. So we really do want to see these things being integrated into appointments from diagnosis, right? Not 6 months later, not 8 months later. And especially because the big emphasis here is being proactive, really, right? When you're talking about a disease as aggressive as pancreatic cancer, we want to see a healthcare system that is proactive, that is giving patients enough knowledge to make informed decisions, not one that is reactive, not one that people are having to chase down their options, to really push for something and self-advocate, and then find out that there's barriers to accessing that, or just the unnecessary delays, right? I definitely believe, just after witnessing my mother's case in particular, you know, in her healthcare system pushing for genetic testing. Prior to that, they did not do genetic testing for someone who didn't have a proven family connection or family incidence of pancreatic cancer. They did change that. They as well um, because at the time a free option did exist for molecular profiling, um, so they did make a change at that time and then go ahead and offer that testing of pancreatic cancer. It's very hard to stay on top of whether or not we do have labs that are doing that, especially that are doing that free of charge. Um, this was a service that the Pancreatic Cancer Action Network in the US did offer, even to Canadian patients. Right? And that's the real punch in the gut, is that this service was offered to Canadians free of charge. Meanwhile, when we're looking at our situation in Canada, that was not reimbursed by our government. Many times that wasn't reimbursed through our private insurance. So, that having something out there and then not being able to access that is a huge problem. And it's just certainly disheartening to see that and alarming to see the barriers to accessing that. Um, when we're looking at the reality, the reality of Newfoundland and Labrador, right? It's that genetic testing, sometimes it's delayed. It doesn't happen very quickly. Clinical trials, we're looking at a clinical trial desert, right? It just doesn't exist. There are no clinical trial navigators that are happening locally in our healthcare system. So it's a huge problem, right? It's a huge problem that needs change both on the provincial level, both on the federal level, and those changes need to be happening. And advocacy is great. I want to acknowledge that by saying advocacy is great. It's really great in a healthcare setting. There are absolute changes that you can make to your treatment journey with self-advocacy, but there are absolutely more often than not limitations when it comes to that, right? You can advocate for molecular profiling and then, be have that conversation about it from the get-go in your initial appointment. But if you don't have $3,000 to $6,000 to pop out for that testing, then really it ends there. What can you do? Start a GoFundMe, things like this. Like, it's very disparaging, and I certainly do appreciate the work that advocacy organizations are doing. We're also doing that ourselves, but I think when we over rely on advocacy and inflate the possibilities of advocacy or the capabilities, that's dangerous as well, because we need to identify what can be done by the patient, how advocacy organizations can help, but really identify when it is a problem within our healthcare systems rather than just being left up to the patient to pursue. Palliative care gaps, I think, of course, this is going to vary from oncologist to oncologist. But when we're looking at the gaps, especially when we're talking about, for example, nerve blocks, right? This is essentially a procedure that goes in and deadens the nerve. A lot of times with pancreatic cancer, especially in the late stages, we're seeing incredible pain, incredible pain that patients haven't experienced before. And when the tumor is not encapsulating that area and there's a clean route to go in there, that is a alternative to the pain medications that do exist, whether that be opioids, the different pain medications. And if we talk about these things earlier on, then that kind of avoids, and in particular in my mother's situation, that avoids really having this huge dependency on opioids. While it doesn't, obviously remedy all the pain, it is an option. And those options, we believe that those options should be talked about from day one. These are, I believe, we have to believe that these are fixable problems. I think that when we're looking at pancreatic cancer, it's not a one-shot remedy. There obviously are many problems. There are many structural, um, regulatory policy problems that need to be actioned in order for this to really see the survival rates in Canada increase, right? We're not claiming to have one solution because one solution is not going to cut it. It's a very complicated problem. It requires a lot of coordination among provincial and federal agencies, and we are not there, right? We're not there in terms of our regulatory bodies. We're not there in terms of our drug approval processes, especially personalized medicine is going to create many different treatments. And we're working on an old traditional model that goes through a really systemic treatments and favors approval of systemic treatments that really work on the whole body as opposed to precision medicine, personalized medicine. We need more rapid, there needs to be a reform of those drug approval processes and really to remedy health access and equity and drug access. Um, the actionable problem. We do talk about a lot of times in precision medicine, they talk about actionable mutations, right? And again, we touched on this actionable mutations. That's, having therapies or being able to enroll in clinical trials because you have that specific mutation. But when we talk about Newfoundland, really one problem here is that we don't have actionable information, right? We have, even when you have enough information to understand that this could be a possible treatment option for your treatment journey, the reality is there are so many barriers that it's likely not feasible for you. Um, so without this happening, without us addressing molecular profiling in particular, we're going to continue to see very low survival rates for pancreatic cancer. We're going to see very low clinical trial participation, particularly here. But it's very alarming. We can't really act on a diagnosis if the only option is leaving the province, right? If you have to leave the province, have to leave your support system, then that's very concerning. So with that, what are we announcing today? So our major announcement today really is introducing what we're calling Port to Care. I have a very not. This is a graphic for it, obviously needs a little work. We're not focused too much on the graphic, but what is this? So we're starting on a little bit modest here. This is reflective of our capacity as a nonprofit and what we're able to offer. Obviously, this will increase as we ramp up fundraising effort. Just for context, we are a nonprofit organization. We have already applied with the CRA to transition into registered charity status. And as many of you may be familiar with, that gives us the ability to issue tax receipts. And that's a big thing, right? Not only just with the tax receipts, but especially because federal charities have a stricter oversight and procedures, and Canadians are more inclined to trust charities over nonprofit organizations. But we have started that process, and it does take time. And we did take some time to really look at the landscape of pancreatic cancer care, especially where we fit in amongst other nonprofit organizations. The space for nonprofit organizations is pretty small when it comes to Canada, but I think we have at this point really identified where we can make a difference and not just grasp at straws or duplicate research or duplicate offerings by other nonprofit organizations or charities. I think the big emphasis for us is really, accountability, transparency, and we really want to make sure that when we're offering things, it's within our means and that we're open and transparent about how the fundraising process works and how we will ensure sustainability for those offerings. So Port to Care is a $500 travel relief grant for Newfoundland and Labrador living with pancreatic cancer. We will expand this very shortly to other provinces in Atlantic Canada and other rural communities. We recognize that it's not just rural parts of Newfoundland, it's also rural parts of even Ontario, right? Like when you're living in rural communities, having to go to higher volume cancer centers, there definitely is. The financial barrier is the same for someone in Ontario as it is in Newfoundland and Labrador. So we recognize that $500 one time is not going to cure all the issues, right? But it definitely, I think, will represent relief. It could be used in combination with other grants as well as part of the application process. If you receive grants from other nonprofit organizations, so charities, that's not something that we're looking to disqualify people with. So I think when it's in combination with other offerings from nonprofit organizations or other avenues, I think it can really work out great for people. And the qualification is simply those who need to travel to access treatment. It is for, only for those with pancreatic cancer. I think it represents a modest, immediate practical help for barriers, especially financial barriers. And again, as we grow as a nonprofit, as we really start to ramp up our fundraising offering, we will make sure that we scale this up as well. We do have to acknowledge that there is a limited capacity for this right now, but of course, as we scale, we do plan on offering more of these grants. It's just really like targeting those grants and identifying unmet needs and the patients who would benefit from those is a big deal. Another initiative that we're looking to fundraise for and that we plan to launch in 2026 is called From Coast to Cure, which is here. And that's probably something you saw at our events. Um, so what is this aiming to remedy? What this is aiming to remedy is really the research inequity when we look at pancreatic cancer research funding. Just to give you an idea, um, Canada in general, when we look at Canadian research funding, and this is something that we're in the active process of auditing right now with our policy project, is really how much of research funding is being allocated to pancreatic cancer. When we look at pancreatic cancer, it's currently the third leading cause of cancer death in Canada. And that's projected to move into the second leading cause very quickly. But you're looking at really a 2 to 3% allocation of research funds in pancreatic cancer. And that's very alarming, right? You think about it, it's seems to be the second leading cause of cancer death in the country. And it's 2 to 3% of research funding. So if that doesn't alarm you, I don't know what does, especially given the low survival rate and increasing incidence among especially younger generation. You're seeing more people pop up with pancreatic cancer in their 30s now more than ever. So as we see increased incidence and we see no improvement in survival rates, why is there not more research funding going towards pancreatic cancer, right? I think that's an important question that we need to ask, not only of funders, these organizations, major cancer organizations, the Canadian Cancer Society, why is more funding not going into pancreatic cancer in particular? So in terms of government and, government commitments, is that something that's possible for government to commit to? So we have to look, especially we have to take a hard look at research funding for cancer in Canada and just ask, why so little going to pancreatic cancer? It's definitely concerning. And when you look at a survival rate that hasn't budged in 35 years, that's too long. That's way too long, and progress needs to happen now. And not to compare apples to oranges, but if we look at the United States, they've seen in the last, I believe, 4 years, an increase from 10% to 13% in survival rate. And you think, that's 3%, but it will take a long time. And even to look at a 3 to 4 year kind of time period and 3% change in overall survival is absolutely progress, right? And that's not something that we can say as Canadians that we've really witnessed. And that is concerning. So that's absolutely something that we want to try and remedy here. So what we're seeing when we talk about research and equity, right? What is that? Research is often concentrated in the provinces Ontario, Quebec, Alberta, British Columbia, right? And what happens with that? what happens with that then is we really see the research going on in these metro areas, and then that filters over into clinical trial offerings, right? So where are all the clinical trials offered? This is something that we really raise concerns with in our petition. That petition represents the first parliamentary petition that's focused on pancreatic cancer. That ultimately, the first one, E5186, was not successful as the government dissolved, obviously with the election. And then E6492 was our secondary. And that is the first Canadian, that's a parliamentary first, and that one passed. They needed 500 signatures, and our MP, Tom Osborne, will be presenting that in November. So I think that's definitely reassuring. Yeah, and I don't know how much actually comes out of petitions, but obviously we're willing to follow up on that. And that just represented really one of our first actions as a nonprofit organization. And then obviously we're going to scale up from here, and we have many plans in the works to remedy many situations. But because we see so much research funding going into these large organizations, right? Toronto in particular, whether that be, and that's not to bash any of these organizations, obviously. You see a lot of research funding that's going predominantly into Princess Margaret. You're seeing a lot that goes into big hospitals and organizations in Ontario. And what this does is essentially those research fundings in these institutions are really mirroring the bigger problem with clinical trials, right? So if we continue to just allocate the research funding to researchers and research institutions in these bigger provinces, then that's where we're going to continue to see the majority of trials take place, right? And really then who suffers from that is the patients outside of these metro areas. And then you see the treatment journeys, particularly for those in Toronto. If you compare the treatment journey for someone in Toronto versus in Newfoundland, then you're seeing completely different treatment journey in terms of what they're able to pursue. And that's not saying that everybody has insanely different outcomes. And of course, we do acknowledge that the survival rate is low, but you're not giving equal opportunities to all Canadians, right? Why is it that the options are so variable across rural areas of Canada in comparison to those metro areas? So I think what we need to do now, really what our focus is now, is to diversify that research funding. And this is not just a conclusion that we have really arrived at. It's also something that in talks with stakeholders, different partners, advocacy organizations, like, yeah, we really need to question, okay, when we fund research, who are the researchers? Where is this research directly going to benefit? Is it going to continue to reinforce kind of those barriers that already exist by continuing to make research benefiting those metro areas, or is it also going to spill into rural areas or smaller provinces of Canada? And this is a definite concern. So yeah, that infrastructural bias, trials being approved where infrastructure already exists is a big concern. And that cycle will continue. Research dollars flow where research is happening. And Atlantic Canada in particular is continuing to fall behind, right? Not to the lack of need. There is a definite need. I understand the population itself may be not as big as bigger provinces. It's not as big as in Ontario, and it's not as big in Alberta, I'm sorry. But if we don't make changes now, then the trajectory really stays the same, right? So we're going to continue to fall behind, not due to the lack of need, but really like the lack of inclusion in design, and also that the research funding will continue to benefit these big cities. So with that, from coast to shore, what that is going to do, what we are going to fund, right? So what this does, this research grant that we're planning on offering, what that does is really prefer to remedy that situation by really allocating research to or trying to prioritize research that will happen in Atlantic Canada as opposed to those bigger provinces. Um, the application guide, as well as some of the procedures, their exact launch dates, we will have them on our website shortly following this regional update. And researchers will be able to go on there and see like the amounts, how much we plan on offering, some of the application guide, and that will all be online very quickly after we finish this update. So what we're really looking at funding is early detection. Early detection is really supposed to be a game changer, especially because people don't talk about this as much, but when we look at pancreatic cancer, stage 1, which is rarely ever caught at, has a 41% survival rate, right? Overall survival. So it's low, it's still low, but when you look at a comparison to 10%, and bear in mind that 10% is the overall net survival for 5 years. So when you look at people who are diagnosed with stage 4, that plummets, right? That plummets a lot. That's, I estimate around 3 to 4%. And if you then add in barriers, right? Like stage 4 in Toronto, maybe you have other options. Stage 4 in Newfoundland, what are your options? There's no clinical trials. So what are your options, right? It's just, there are no options. And then that's the survival rate is lower, unless you choose to move. And again, that comes with a whole set of barriers. And really, this shouldn't be an issue, right? Like it should be something that we start to alleviate. We do have like different conversations ongoing with kind of industry leaders, other regulatory bodies, and there are solutions. We've talked about this many times in our petition, as well as a lot of our online material. There do exist satellite centers. There is a craft framework that has been developed by 3CTN that does have the potential to really change how Canadians are participating in clinical trials while we're waiting for the infrastructure to equalize amongst provinces. And that probably is a long time. That's a far way out, right? So the goal of this research fund is to really allocate funds to researchers from Atlantic Canada. And the pitch with this is when we're approving research funding is to see, okay, will this have a tangible effect for people living in Atlantic Canada? Or is this, just going to Toronto, right? So we really want researchers, and then you'll see this in the application guide, demonstrate how the research is poised to affect Atlantic Canadians and what some of the benefits are, right? So that is something that we were thinking about and definitely in talking with partners and especially with our ongoing policy project. It's like, yeah, we have to start diversifying research funding, right? It's something that particular Craig's Pass is doing a amazing job at. And I think that helps. That's amazing. I think they're definitely leaders with that. However, I do think that, Atlantic Canada in itself is large, right? And that, that benefit also has to filter into Newfoundland and Labrador. And I think having a dedicated organization now that's going to, fight for that, advocate for that, really try and attract research here, and then, as well benefits for Newfoundland and Labradorians, and expect that as a standard. I think that's very important, and that's something that we're looking. So I'm just seeing if I'm missing anything, and then I will go quickly into our meeting with government. What we will find, yes, in addition to early detection, right? So early detection is something we really are concentrated on. There is an outgoing trial in Toronto as well that's taking a look into this, obviously much larger scale, and we're familiar with that, are really excited to see the outcomes. Rural care access, like we will also fund projects addressing care delivery in rural communities. Clinical trial include models that include Atlantic Canadians from the start, and then especially precision medicine initiatives and ensuring research reflects the full picture of the caring parent. So that diversification of funding, um, who gets funded and what questions get asked, that regional focus, really research that's delivering tangible benefits for Atlantic Canadians. That's something that is the focus and that we're looking at a remedy with this research grant. And it's starting small as well. We realize that research costs money. Like $100,000 wouldn't put really like a dent in many research initiatives. So we expect as well, starting out modestly with this, that this research grant in particular will be utilized in combination with other research grants to really band together, um, offering a researcher can take advantage of ours along with, another organization, and then realistically improve access to better outcomes for Canadians, but also to diversify that research and make sure that we are represented in Newfoundland and Labrador across the broader Atlantic Canada and throughout Canada. So next I just want to go into quickly with our meeting with government. We had a meeting actually, this was 2 days ago, with the health ministry on pancreatic cancer policy in Newfoundland and Labrador. This was, I think, particularly very exciting for us because we're more than happy to see that government is willing to take a meeting, willing to engage. I think that's the base level of kind of interaction that we can hope for, is a space in which we can really voice concerns and, feel that we're being heard. So the way that meeting was structured, it was attended by myself as well as my community director, Lisa Gillespie. We also brought on two really powerful caregiver voices, Ramona Kellaway and Greg Pike. They spoke as well. I believe like you will probably see, if you looked at some of our shorts on Facebook, you'll see that Ramona gave a really good speech, and she was a personal close friend of my mother as well as, a registered nurse. And when the nurses are telling you issues about the healthcare system, right? And they know this more intimately than anybody else, then listen to them, right? I think they've been in the healthcare system for so long, but I always remember my mother being, like I've been working in the healthcare system for 35 years. And when it came to cancer care, she just felt completely floored. She felt, oh, what do I do? And when you're undergoing like chemotherapy, you're undergoing cancer treatment, you can't be the same advocate, yourself when things are hard, when things are trying, when you're like under the weather or really having these treatments and be expected to really self-advocate all the time, right? A lot of the time, this role really falls on caregivers, right? So that's the family, friends, whoever that may be that's helping out, that person with pancreatic cancer. And unfortunately, what we see with the low survival rate is that these testimonies and this feedback and just lived experience, it oftentimes comes from caregivers rather than the patients themselves, because many times they're already dead. That is the harsh reality with pancreatic cancer. So we exist, they exist, right? Caregivers exist to really tell their story. If we don't highlight those voices now, then their story, the experience of Canadians living with pancreatic cancer, when they pass, it ends with them, right? And we can't really rely on healthcare systems. We can't really rely on surveys to paint the whole picture of what the experience has been. And I think caregivers, especially, Ramona and Greg and myself with my mother, you're doing such justice for people who have gone through this journey with pancreatic cancer and who have experienced those barriers really firsthand, because people need to know that, right? Like people need to know what is happening in our healthcare systems. They need to know what the realities are. the improvements that we can make. And I think these this experience then has to be brought to the right audience. I think government is obviously a great place to start, especially provincial, but obviously this has to spread across the general public. It has to spread to the federal government. We need to see coordinated action. It's not going to change with one meeting with government, not going to change with one petition. This has to be a coordinated effort. And that's where we think as an organization, I think it's one of our strengths. And, coming into this right now, we really just wanted to make sure that we were having conversations with everyone. I think what we've done differently, and I'll quickly touch on this, I realize it's almost been an hour. Um, what have we done differently? I think it goes back to our core values being transparency and accountability is a big thing, right? So with that, we currently have a program that we're developing. It's ongoing. Of course, we're making refinements to that. We currently have 11 students at Memorial University, right? And what we're doing is doing a national audit really of Canada's response to pancreatic cancer. And part of this project is really landscape analysis that's looking at, provincial government, federal governments. It's looking at different health organizations, advocacy organizations, their initiatives, their capacity, their track record, hospital systems. It's looking at guidelines. It's looking basically at everything, right? We want to go in there and brilliant students and brilliant work. And the incorporation there really of, I think, where one of our benefits is as a young organization, we are really, as a demographic, familiar with artificial intelligence. It's something, especially the generation that comes after mine, it's something that has been like computers were for us, right? For my generation, if you know how old I am. But so yeah, that's definitely a benefit there for us. As my community director, what Lisa would say, work smarter, not harder. Obviously, we do need to work hard, but I think, yeah, that policy project, we're looking at innovative ways to optimize our work process, especially, nonprofits, new nonprofit organizations. You have limited resources, but we want to make the most of our time and we want to make sure that we're in impact, right? So that's an ongoing project. It's a 16-week. Obviously, we're a little behind schedule now, but it's a 16-week project in collaboration with the students, and we're really looking to do an audit of how Canada is responding to pancreatic cancer. And how does that look? We're looking at things, everything from these consensus on biomarker testing to craft that model. And that brings us really to our approach, right? Our approach is not to just scan the internet for what's going on. Really, in that project, we're encouraging to, and we have been reaching out to stakeholders, whether that be initiatives, whether that be other advocacy organizations. Built into this a component which is called the Stakeholder Speakers Series. And what that does is invite speakers from different stakeholder speakers to come on and host like an hour session. And what that does, introduce that body or that person to our policy group that's doing the national audit and really let them know about the initiatives and what's going on with their organization, right? Because there's so many organizations and they're all doing different things to, act in the best interest of Canadians. But a lot of time that information is not just going to be accessible to the public, right? A lot of the times there's stuff that's going on behind the scenes. There's values of an organization that when they come and interact with the policy group, it really gives them an insider look into information that may not be publicly accessible, right? And it may not be plastered over the internet. And then, we want to look at like, what are their future goals? Like, what are they looking to remedy here? And some of the policy, gap analysis, like all these really interesting things. And I think it's it's just a really valuable experience, and being able to renew this program, I think every year, it'll accumulate in an annual publication, and then we'll publicize that to identify some of the areas where we think we are lacking um, across in our response to pancreatic cancer. What are some of those barriers? What are some of those initiatives that are working and that are poised to really benefit Canadians? And I think going back to the core value of that is accountability. And I think as a broader value within the organization is to really emphasize um, engagement with youth, right? Because youth is represents like the next generation, right, of policymakers, of of medical workers, and pancreatic cancer awareness remained low. It remained low when we did our event with Pride. It was like the amount of people that came up and didn't know what a pancreas was, and I'm university educated, and I didn't know what a pancreas was before my mother was diagnosed, right? So a lot of the times what we're looking to market, and it's extremely difficult to market pancreatic cancer, right? Because if I, even personally, I think about, did I care about pancreatic cancer before my mother was diagnosed? And the answer was no. So it's challenging. It is very challenging to market, as I said before, to get people to care about this cause. But it's a health crisis, right? It's a Canadian health crisis, it's a global health crisis. And the reason being is just simply because there has been no progress that's been made, right? And not only that, we just don't have the attention. Like pancreatic cancer does not have the attention that lung cancer or breast cancer does. And then when we look at, the amount of funding that's done into breast cancer, and we do see proven benefits, right? You look at breast cancer now, they have early screening, right? So they're able to develop ways which they can catch cancer earlier. And when we catch cancer earlier, that's when it's actionable, right? That's when we can make a difference. So we want to see that for pancreatic cancer, right? So the amount of research funding is a concern. It's very much so a concern. So we need to ramp up our fundraising efforts. We need to ramp up our awareness efforts. And that's something I'll get into with government and how that reading went. So, going back to that, I look a little shocked because I think I talked about it and then I went off there. But what were some of the concerns? So I just went to briefly about the organization of the meeting and what were some of the things, that we raised. So going into that meeting, of course, there needs to be a little bit of understanding, right, about pancreatic cancer. So we spent some time really to identify the Heather Cutler Foundation, what we're about, but also, what is pancreatic cancer? And that's very condensed. We talked about what the optimal kind of treatment journey should look like, what a diagnosis should look like, really the importance of informed decisions. So, encompasses like education, awareness, talking about genetic testing, somatic testing, and of course, the results of our focus groups and our surveys were that almost 100% of the patients in Newfoundland and Labrador were not familiar with that. Um, in some focus groups, caregivers were not aware whether or not that was an option, or whether or not their loved one had genetic or somatic testing. And that is very concerning because what do they do? It's concerning because if we don't have this testing, then we're not giving patients that option. And if we're not giving them that option, then we're telling them to, more times than not, to get their affairs in order, go home, and that's it, right? That's all we can do for you. And that's not good enough. It's not good enough, and that needs to change. So what do we talk about specifically? So again, we went into, that primer on what pancreatic cancer was. We went into the reality of pancreatic cancer in Newfoundland and Labrador. As I just said, like with the testing, that remains an issue. And then of course, we had caregivers that spent 10 minutes of really letting government know how this looks, right, for caregivers. I think a lot of the times that we don't talk about, and even myself, we can't base lived experiences not just from one person. It's from a collective. It's from a lot of people. And when we speak to those experiences, we can find certain commonalities between those experiences, right? And then identify, okay, this is happening across, this happened to this person, this happened to that person. And as that kind of like sample size gets bigger, we can see, okay, like a lot of people are experiencing this. And this is definitely like a bottleneck here in their treatment journey. So I think ongoing surveying, identifying patient populations is important. Um, a barrier for us as well as an organization because, really we need people to be able to find us. We need people to be able to go and say, okay, I have pancreatic cancer in Newfoundland and Labrador in Atlantic Canada, right? And then for them to see, to engage with advocacy organizations like ourselves, like Cred's Cause, like Pancreatic Cancer Canada, and then be brought up to speed very quickly. Because it's such an aggressive cancer, we need to make sure that people are not spending half their time trying to really be like, what are my options? Why wasn't I offered this? Oh, what is going to be an access issue in Newfoundland and Labrador? Um, I didn't speak so much as to my mother's experience there with the healthcare system, because really I wanted to lend an ear to other people's experience, right? And just hearing it, I of course thought to myself that, okay, exactly like my mother's, right? There is things that are, they're commonalities and they need to be changed. And whether or not government is, ready to really take concrete steps towards that will remain to be seen. I think what we demonstrated really and what we tried to communicate within this meeting is that as an organization, as the Heather Cutler Foundation, while we were very critical in some of our concerns about the healthcare system, we also want to ensure that we're remaining open to communication, that we're being collaborative, that we continue to engage with one another. I think government is very busy. So there are obvious capacity issues, and that's mirroring across all the public sectors. And I think healthcare just for everyday people is a concern. We're over capacity, we're understaffed. Oncologists are definitely um, burnt out. We've read a lot of studies about that. We are inherently aware of these issues. However, that doesn't change our stance, right? I believe there are ways in which there are solutions. There are definitely solutions in the short term. There are solutions in the long term. So some of the potential ways we went into a section then about how the provincial government can help, right? So if we just excuse me for a second. Dad, one of the perks of having reading at home. So yeah, so we went into some of the ways that we think the government can help, and unfortunately, um, early detection, right? So early detection is going to be something that kind of really revolutionizes like pancreatic cancer, will boost the survival rates by a lot, right? Um, so early detection is um, that's a it's going to represent a big change in pancreatic cancer, and that's something that when we arrive at that point, it's not something that is dependent on clinical trial outcomes. It's something that, can see immediate benefit to patients. And there's certainly ongoing studies and research into that. Um, so early data, when we look at high risk populations, right, there's a study that's ongoing. It's a consortium, I believe, is happening multiple trial sites. And essentially what that is looking at is the feasibility of screening high-risk populations, right? And when we talk about high-risk populations, essentially what that is focusing on is people with a familial history of pancreatic cancer in combination with new onset diabetes. And that is while we're looking at risk factors, right? And this, unfortunately, like symptoms are not, they don't present a lot of times. They may be vague and like, okay, know the symptoms and listen to your body, right? And I think that that's super important. I think in one of the potential solutions that we talked about with government, I think it's important to get that out there, even if the research is not hasn't met the threshold in which a government decides to act. The importance of getting that information out there and being like, hey, this is being studied. There are efforts to understand this, and this is potentially where treatment pathways could go. It's important for them to know that. One of the things that we talked about, and if not able to be rolled out now, is the addition of pancreatic cancer as one of the electives for self-elective screenings in the My Health app in government in Newfoundland and Labrador. They have the My Health NL. I'm not completely sure again of the two. I believe there's two options for self-elective. Cancers, I think what would be beneficial when, these studies blew up, if there's not enough supportive, if the threshold hasn't been met to prove to government that, okay, it's worth us to take a look at these high risk population, if we monitor them or add self-elective screenings, then is that going to see a tangible benefit for patients, right? I would argue yes. They're also looking at things like capacity. When we put in new self-electives, then people are going to, well, obviously there's going to be an uptick in people who are looking to get screenings, right? So at the end of this week now, we're going to send along like the information, the current studies, what's ongoing, just to inform their decision. While it may not be something that's supportive now and may not meet that threshold for them to justify adding that to self-screening, um, it's definitely, I think that would be a step in the right direction with those high-risk populations, especially those who have pancreatic cancer, a history of pancreatic cancer in the family. If we can sidestep, even that doesn't just mean, okay, I should be proactively going and doing screening. But what if that patient was experiencing like back pain and they have to get in and see their primary care provider, their family doctor, and family doctors, people, not everybody has a family doctor, right? So what if we could really like sidestep that process and then have patients who are presenting with those early warning signs of pancreatic cancer? A lot of times it's that back pain, right? It's that kind of weird back pain that you haven't experienced. And um, in that meeting, right, that was something that presented in my mother's case. It was something that presented among those two patients, those two caregivers, loved ones as well. So if we can have people self-elect for scanning, right, then that means they bypass that with their doctor, right? Certainly you would encourage them to speak to their provider about that. But because pancreatic cancer is so aggressive, and then we talk about in advocacy, trust your intuition, right? Really trust what your body is telling you. So if we're able to add that to the self-elective screenings in the My Health app, then, we feel certainly that would be beneficial. And, we kind of, is this something that's a reality to pitch as a pilot project, right? Maybe we could do something in a year, just look at it, see if that had any benefit to changing the outcomes for people with pancreatic cancer in Newfoundland and Labrador. So I think that was one thing that was, we just wanted to get out there. I think in addition to that, what we talked about, and this is important, is awareness, right? Awareness is very important. It's not as exciting as impact, obviously, but everything really starts with awareness, right? If people are not aware of an issue, then they don't care about it and they're not really thinking about it. So November is Pancreatic Cancer Awareness Month. It's also the 21st World Pancreatic Cancer Day. We've made a lot of efforts now to go in and do individual proclamations for every single municipality. In Canada, we have a database of every single one. We have contacts and we're reaching out to them with, again, this is the benefit, I would say, of AI, especially when it comes to repetitive admin tasks, is being able to kind of just pitch out like a template, send that to a government context and be like, hey, can you bring this to council? Can you recognize World Pancreatic Cancer Day? Can you light up purple if you have the capacity to do so? So, we're definitely focused on awareness effort. I think, especially, as we move into our first 10 months, in November, we would like to see um, the government support our awareness campaign, and they have really advised on that, and we'll get in touch again in the fall. And that's something that they're on board with, really in promoting that on government channels. It's definitely encouraging to see that. Um, I think once we garner once we increase awareness, then we're also increasing support. And then naturally, that will filter more into, other areas and really getting momentum going. Um, I think just when you look at advocacy, you look at awareness, there are many things that people can do on any level, right? And a lot of these things don't cost money, right? If you look at the organization in the past 9 months, it's something that I have funded entirely from my personal finance. And when you look at like the attention we've gotten, the kind of different changes we made, like the advocacy, the parliamentary first with that, the proclamation, like all of these things are accessible without the need for mass funding, right? So you really have to, I think, before we introduced patient grants, we didn't have a need for fundraising. Right? Of course, um, fundraising is important. It's um, also something though that I think you really need to take time, both myself as an executive director, both in really serving well, patients. We don't like to say patients. I know I might have repeated that a couple times here, but I think Canadians living with pancreatic cancer, Newfoundland and Labrador living with pancreatic cancer, I think there's no benefit in patients is something, it does not like your mental health. Like I prefer to see the person instead. But going back to that, I think fundraising considerations, like for us, why did it take us so long, right? Is because you really have to think about, okay, if we're going to ask for money, right? Or if you're going to fundraise, you need to have a clear pathways that when you donate this money, this is going to go to that, right? So I think really identifying what is the need, um, how can we support Canadians living with pancreatic cancer, but what movement can we make toward leveling the playing field, encouraging equity and access, not just for Newfoundland and Labrador, but for all of those provinces that are outside really metro areas. So I think that's important, and that's why we're starting out modest, and why we really have I wouldn't say limited offering, but I think really we need to take a lot of thought, and be very mindful of what we're asking for. If there is a clear impact that those programs are going to make, and think about what is our role, right? What is our role within Newfoundland and Labrador? What are Newfoundland and Labradorians expecting from the Heather Cutler Foundation in particular? And really meeting that need, really meeting the public's expectations of us. And I think none of that is going to be accomplished if we didn't really take a look at what is the current landscape of care, of advocacy, of existing organizations, charities, nonprofits, and is there something that's already ongoing that we can support? Is there an unmet need that we really need to craft like a solution for? And I think that will develop. There will be additional like offerings and actions that will, definitely we will talk about as we go through that process, as we learn. I think it's not something that we are super want to rush, because when you rush things, obviously, it's going to not be, it's not really going to take into consideration all the information and the data that we should. So I think that's very important. So it was encouraging, yes, to see government really commit to, I think, in November, with the awareness campaign. I think that's a great start. I do think that awareness itself is not, it's not the end all be all. There has to be other actions taken. I think continuing to go back and really have communication with government is an important thing, especially as we do see policy changes, we do see the landscape changing. I think ongoing communication, especially with organizations that are in the front lines with pancreatic cancer, is important, and it's important to really hear these concerns. Lastly, and not leastly, another thing that we brought to the attention was Onivide. Um, I don't know if I'm allowed to reverse to one drug. So this represents the third chemotherapy option, right? The chemotherapies that we have that are the standard of care are, and I don't want to make an error here, but are FOLFIRINOX, and then gemcitabine nab-paclitaxel, right? So these are two, sometimes depending on the patient, like they may withdraw like one of the components. I think they're especially for FOLFIRINOX, like that's a very heavy chemotherapy, and people in general are less tolerant to that as comparison to gemcitabine nab-paclitaxel, right? So what we do have is a third chemotherapy option, right? This is called Onivide, I believe, and I just don't want to make a mistake when it comes to this, but I believe what's happening there is, so just to give you an idea, the pancreas, right? When the tumor, what's different about a tumor of the pancreas, right? So it forms like a stroma around it, and that really is, it's a problem because it makes it harder to penetrate, right? It makes it harder for those drugs to treat that tumor. Um, so I think what Onivide is trying to accomplish with this is I think it's one of the components of Farinac, I believe. And again, I don't want to make a mistake here, but I believe it's encapsulated, and the encapsulation process ensures more like targetable delivery and penetration of the drug to the tumor, right? Again, I'm not an oncologist, I'm not a medical professional. I do in the day-to-day try to grasp your best understanding, but ultimately this is the conversation that needs to happen with like your care provider. So what happened with Onivide is that this was approved 7 years ago. I believe it's now leaning more toward 8 years ago by Health Canada. So in terms of drug approval, how this works in Canada, this is an oversimplification, but how this works in Canada is that a drug is brought in, it's approved by Health Canada. Canada's drug agency actually does a review. They do like an open call for like clinician and patient input, and then they issue a recommendation. And this recommendation then goes to the funding body, right? This is not whether or not Canada's drug agency issues a recommendation. This doesn't mean that something is going to be funded. And as it happens in Canada, yes, while Health Canada may be a federal approval, each of the funding decisions are made by the provinces, right? And a body that's really negotiating these funding processes is called the Pan-Canadian Pharmaceutical Alliance. And this is something that when we first started out as a blog that I was looking into, and I've since learned more about this. I've, spoken to stakeholders about this, and it's a body, right, that will essentially, on behalf of the provinces, negotiate drug funding and reimbursement. So 7 years ago, this was approved by Health Canada. With the Canadian Pharmaceutical Alliance now, for 7 years, this drug has been unobtainable for Canadians living with pancreatic. And the fact that there's an unmet need is not something that's up for debate. It's a 10% survival. There are two approved really standards of care. There are some immunotherapies, there are clinical trials ongoing, but it's an unmet. That's a no-brainer. So the unmet need is definitely something that's there. When they did, obviously, this is a drug that went through the whole clinical trial process, right? There is a benefit. This is something that's offered in America. I believe there is, I don't know if it was, I may be mistaken, but I think there was a clinical trial that compares this to the standards of care. what's important to note here, right, is even if you don't see a super, like over like improvement in overall survival, um, that doesn't mean that okay, this drug has no benefit, right? Um, it represents another option, right, for chemo, like for Canadians with pancreatic cancer. And just what's so infuriating is this isn't an issue of whether or not this medicine is effective. It's not an issue of whether or not Canadians need this medicine. It's an issue of something being approved and then it being stuck in a regulatory process and then that being not obtainable for Canadians, right? So this agency, if you look it up, that regulatory body, they are exempt from a lot of things. They're supposed to be working independently from the Canadian government. There are some disputes as to their kind of proximity to the Canadian government. Um, Nonetheless, these disputes have for 7 years now resulted in no funding for these drugs. So they haven't arrived at an agreement. Um, I've been told that the manufacturer came even to offer this at cost to patients, right? So we're talking about at cost, like they're essentially market price, right? This has been offered to Canadians, and then it still no agreement on funding, right? So what this means is essentially Canadians are not able to access this treatment, right? So we really have to, I think, beyond, and that this was one of our attempts with the petition. And again, a petition may at most just amount to a weird, but what I think we really need to understand is that a petition garners attention, right? It puts something on the record. When I look through the House of Commons, this was a year ago when this was still a blog and doing preliminary research, there was nothing, right? Like for pancreatic cancer, I believe there have been some conversation in the recognition of pancreatic cancer as a known a risk for firefighters, right? And I think that was something that Pancreatic Cancer Canada had championed. But in terms of petitions for pancreatic cancer, nothing. And beyond that, are some transcripts that are just talking about pancreatic cancer in the context of it's something not relevant to pancreatic cancer, right? And it's a long time ago. So I think that is very important. And I think we have to continue to kind of action, provincially, municipally, federally. Like a lot of the times when you start advocacy at a lower levels, that's where you're going to see some movement, right? Because those people are typically more accessible than reaching out to the Canadian health minister. Right? I do think that in the future we will move more towards, if we don't see, some movement on it. And again, this is something that Pancreatic Cancer Canada, this is something that Craig's cause as well visited, and there was no change, right? So the fact that these organizations went in and demonstrated an unmet need with patient advocates as well, and we still haven't seen that drug approved for funding across the provinces is insane, absolutely insane. And to be sitting here talking about a third treatment for Canadians with pancreatic cancer, and then be like, hey, we have something 7 years ago that was approved, and we just don't have access to it, is it's very alarming. And that, that body in particular, you're not able to submit like a freedom of information request. Like the transparency in that body is non-existent. So that's definitely a concern. I think looking forward, we probably will move toward call campaigns, mail campaigns, phone scripts and things like these, like putting people in touch with via website or an email campaign, putting them directly in touch with MPs or other members of government to champion this cause and then really gain some momentum for that. I think when we look at our change.org petition, we try to loop in everything, right? So not just this one thing happening here, or this one thing happening here. What we try to do is mirror that momentum across change.org, across our comments, across our blog, our social media. Everything is of what we see is repurposable, right? Reusable. And why should it be any different? As an organization, your base mission at the Heather Cutler Foundation is we're to work towards our vision is Canada, where pancreatic cancer diagnosis no longer means saying goodbye. And I think that's simple. And then our mission is simply to improve outcomes for Canadians living with pancreatic. I think it's a no-brainer, right? Um, but that did take several times to chop down that mission statement and outlook. Um, Eventually, yes, I think we will move towards, you know, garnering public support. I think as well, you cannot underestimate the individual impact of going in and advocating for everything, right? And whether that may be, the approval of a drug, just being like, hey, I want you to like reach out to, and he would be like, oh, I'm really concerned about this. One of my loved ones passed from pancreatic cancer and they weren't aware of this. Or unfortunately, in my mother's case, what happened in particular with this drug was that we had reached out, I believe, forgive me, it's a little bit, still a little bit raw, even after a year, but we have reached out. I remember because I've always been very tech driven, right? So I had started this whole thing, right? It was like my mother is going to have, it doesn't matter what happens, my mother is going to have the same equal opportunity as someone who is in Johns Hopkins, as somebody who is in Toronto. I was like, I will stop at nothing for that. So how did that look for me? I was like on Airtable, right? I was automating clinical trials. I was pulling and scraping that data from clinicaltrials.gov. Um, I was as well creating, like using AI to ingest her medical profile and then spit out a patient profile that's comparing to, and, obviously with um, go against inclusion and exclusion criteria for clinical trials. And then when it was sending outreach to clinical trials, it was like, this is my mother. She's looking for this. And then to cut down on that time. And that's something, I'll get into this, another time. It's a very vast process, and that's something that's happening with different stakeholders and something we want to provide feedback on. But everybody can really action these things and advocate for a cause, right? And like I said, it was with my mother, I just tried at every point to give her the best options. And once you actually go with this, for the people who are tuning in now and being like, oh, it doesn't happen to you, right? Or, it's not something that I need to worry about. Please pay attention to this because you would not believe, right? When you are faced with a disease that has such a low survival rate, and to go in then and then just, I will say this time and time again. I come from an Asian studies background, right? I'm not a medical professional. I'm not someone who has an intricate knowledge of pancreatic cancer other than, what I've studied, what I've self-learned, what I've learned more on the policy side of things. I think we're all continuous learners. So, I mean, and especially in my position, we will continue to learn, continue to adapt, right? But I just remember bringing these things, right? Like you hear these advocacy organizations be like pancreatic enzymes, clinical trials from diagnosis, genetic testing, somatic testing. And then when you go to the actual lived experience of these people, and they're not talking about that, right? Every single one of those things I brought into my mother's appointment. I remember every single time it was really like, I'm working with like, okay, scraping clinical trials, scraping all the medical studies every day. What advocacy organizations are doing? We used to go into the appointment. My mother, yes, of course, there's a huge mental health aspect, right? And there are things that need to be said with her. But then because we have such a limited time with oncologists, right, we're trying to really maximize that time and be like, this is why we need to. What about clinical trials? What about pancreatic enzymes? Like, pancreatic enzymes are huge. They improve the overall survival. They stave off, um, and Kim pronounce this right. Yeah, or CSCGSIA. of the weight loss and really an inevitable kind of a weight loss and failure to absorb nutrients that comes with cancer, right? And these were not conversations that were proactively had. These were things that I went to and then said, we want to talk about it. And why wasn't this offered? And I left those conversations being like, why wasn't this offered? It's not to say that everybody has the same opportunities. It's to say that, and it's not to say there is a privilege in cancer care, right? But it's to really be astonished at why wouldn't they mention that? Why is somebody else making a decision for my mother or for somebody else and just failing to mention that? What we went through, and this is a belief of myself, and I think it's something we'll continue to, go with this organization, is that within those 2 years, those things that we learned, right? I could list them all on this piece of paper. It could be a bullet point, and then unfortunately, we're very limited into what we can distribute as an organization in terms of medical advice. And as always, like, you need to speak to your care provider about this and not go off something off the internet. But it's 2025. People obtain their information on the internet, and it's definitely something you could bring to an oncologist, right? And be like, I want to talk about this. So it was really comparing, I think, many times. This is happening. This is offered in Toronto. Why are we talking about this in Newfoundland? Or this is ongoing in the States. Like, what are the barriers to accessing that here? Um, so that was a big thing, right? And for me, my jaw dropped time and time again when I went into this with a confidence being like, okay, somebody who is studying oncology, somebody who is intricately familiar with his disease is, of course, going to advocate for their patient. It's, of course, going to be proactive about offering these things. And they should be at the top, the very top of what's offered and the development, right? But that wasn't always the case. When I tell you that pancreatic enzymes, that was something we brought up. Genetic testing. Prior to my mother's case, I know that the health system was not offering genetic testing for people who didn't have a demonstrated family history of pancreatic cancer, right? That changed. If you look on our videos on this page, you will see the actual recording of that, like my oncologist letting my mom know that because you went through this process and because you advocated for this is something that we're going to change and proactively like offer to pancreatic cancer patients. So I think very early on for that demonstrated to me our advocacy and what you were able to change, right? And then on the same side, it also demonstrated to me what you are not able to change. What are barriers and what are the power and advocacy, the limits of that. So I think these are things that, anyways, we're getting into the depths of it here. But these are things that are very important to talk about. But Anavai, so again, going back to Anavai, um, again, I just touched on, got sidetracked there, but I think it's important for us to, be looking at other ways in which we can really bring this issue to light beyond the petition, really engage with the broader public, and to bring these concerns to not only government, but as a collective voice. And I think anytime, even as an organization, we approach things, it needs to be collective. There's power in numbers. So we raised that concern with Anavide to government. That's something that they are going to revisit, and that's reassuring. I think it's something that we went through with the family, with the healthcare system. It was always ask for something, be told like, we're going to look into that, and then you follow up, right? It's always asking, it's always following up. And I think that's something as an organization, as a family, then that I think works effectively. Like there's a lot of things to be concerned about. There are a lot of, interactions with government and they're interacting with other organizations and problems. And it's easy for things to get dropped along the side or not focused on. So I think that's something that we will continuously go back with. I think that's very important because, how can we have another treatment for pancreatic cancer patients and then just it not be available? I think that's where you differentiate for the issue between really science and then, policy, right? So if there's policies that are working against patients rather than for them, there lies the issue, right? There's a problem with it because that's not how it should be. So I think that's something else that we raised. So that was something that they're going to look into. I talked about the awareness campaign. That's something we'll be prepping for now and moving into World Pancreatic Cancer Day and Pancreatic Cancer Awareness Month. The proclamations, we will go into continue to reach out to municipal, federal, provincial governments um, across Canada and see really how many cities, how many governments that we can get to really proclaim World Pancreatic Cancer Day and show their support. I think we really do have a potential, especially as a volunteer-led organization, with kind of our the way that we embrace really AI tech. I think we can make an impact there. And I think, again, this doesn't cost anything. And I just want to say to all the volunteers, especially in the policy project, um, to people who came out in pride, I know we have free cookies, like the cookies were bomb, so I can see why people came. For me, I am forever humble and really appreciative of the people who have taken time to show up, have volunteered for the organization, whether that be through the policy project, to Holly for the cookies, to Lisa, to all those caregiver voices, to Ramona, to Greg. I remember a lot of times, there's a lot of times that people will be like, oh, we're so thankful for this opportunity. And no, really, it's the other way around. This started from a blog, and then to see the traction, to see people really stand behind what we're fighting for, and to know that my mother's experience, I would have not been in this position had it not been for my mother. Um, and I think we do have a chance to really make an impact here. I think just the growth that we've had in the past, 9, 10 months, and the way that we approach things, um, the conversations that we've had, I think we do have a really potential to change things here. And I think we're a relentless voice. I think one of our core advantages over some of the other players in this space is that transparency is a huge thing for us. Accountability is a huge thing for us. If you're able to tune in, I know this has been a very lengthy announcement. If you're still tuning in, I thank you. Thank you very much. I really appreciate you guys taking the time to watch this. Um, there's going to be people who just watched it at the start, and I'm glad that I do just summarize things before I went into the nitty gritty with it. But thank you. Yeah, just thank you so much for the people that came to Pride and St. John's. It's, you know, if we didn't, we had a fundraise prior to that, like that money is it's been such a small amount of funding. I think really where fundraising came in was, now being able to really be like, oh, hey, this is an unmet need and this is something we need to focus on. And I feel comfortable now with moving towards a fundraising model. I will feel much better once we have transitioned into the charitable status. We're able to really have a high standard of confidence and trust with the public and be able to issue those donation receipts. Yeah, that will do a lot for it there. But to see people just interacting cookies and just being like, what is this? This is a pancreas, this is a penis. Like, I think it was a very I think that marketing campaign, particularly like when we went into Pride, it was like, how do we market that? What is going to be the relevance and how are we not going to be there with like a complete damper, right? And then to turn it around and with these cookies and the conversations that ensued with that, I think were genius. I don't think we could have asked for a better outcome for a Pride event. And we also just have people come up to us and like my mother died of pancreatic cancer 15, 16 months ago, or 15 or 16 years ago. Right? And to hear their experience and to be able to really speak to them and then what's the frustration that things haven't changed. Really, like we look at people who were diagnosed 30 years ago, there's not been that much of a change, right? There's definitely hope. There's definitely, that kind of steering towards personalized medicine, but also those outdated systems, it's changes that need to be made on so many levels to accommodate those. Right? So I think just to see the level of engagement is really it's really inspiring for us, and it continues to affirm to us that this is the right thing, like this is what we need to be doing. So I think as an organization, um, we have seen total really great growth. I think that we will continue to expand. I think there's a rush, right? There's not a rush. I think that we want to continue to, serve the needs of the community here and in Atlantic Canada. And I think it's really focusing on having a focus, right? And then as well, more broader focus, but really community engagement is that volunteerism is involving other people with the cause. And I think the reception to that has been amazing. I think as we expand outward now, as we really we're finishing, and we will discuss this on August, in terms of our business plan, in terms of our organizational strategy. That's something that at the end of the day, I want to continue to be as transparent as possible. Because without that transparency, this is the last thing, and then I'll cue this up here. But I think really the value of transparency is this, right? If we're not talking about what we're doing as an organization, um, in terms of the petitions, in terms of these conversations with stakeholders, in terms of our strategy, if this is not something that's public facing, then we're missing out on opportunities for the general public, other stakeholders, to really be involved with. And I think that's something for we transparency, that has to be everything, right? Because that's how you build trust. That's how you let other people know what you're doing and so that they can get involved. I think this is extremely important. And I think it will really demonstrate the um, just our commitment to the cause and what we're actually doing, and then people can make informed decisions whether or not they feel this is something they can get behind, whether that be financially, whether that be volunteering. I think transparency at its core is one of the most valuable assets our organization can have. And as we put into place more activities, this is my commitment that we will continue as an organization to ensure transparency among everything that we do, and especially as that relates to any finance or fundraising efforts. People want to see impact, they want to see trust, and that's certainly something that we want to work towards. So with that, I think I'm queuing everything up here, and I'm sorry, I had no idea that I was going to keep people for 2 hours. But what to look for from us next, and just summarizing here. So the grants court here will go live as of August 1st. There will be an application. I will make sure that that goes out on the website. There will be an application guide. There will be eligibility criteria. There will be a remaining capacity. As we, of course, expand and scale, we will, of course, increase that capacity for patient grants and research grants. The priority is establishing the balance between the two. That will go up in terms of the research grant. The eligibility as well as the application guide has already been completed. That will, of course, go live on our website as of August, I believe August 30th, 2025. So if you want to find out more information, if you have any, concerns, if you want to reach out, if you have feedback, We're more than happy to engage the community continuously at any point. So please feel free to leave a comment, send us a message if you'd like to, an email, give us a call. We're totally open to that. So those two grants, and then we did touch on our meeting with government. We voiced concerns about Onivide and the lack of that treatment being offered in Newfoundland and Labrador. We talked about potentially exploring adding high-risk groups that be new onset diabetes and familial history of pancreatic cancer to the MyHealth NL elective screening. We had caregiver voices there, Ramona and Greg, to voice their experience and some of their concerns. Because I think I left that out, Greg. Shout out to Greg, especially for considering and Ramona, considering the traumatic effect really that pancreatic cancer diagnosis and that experience going through such loss and such trauma really, right? And having to address the ongoing concerns with that, having to really address what happens to families once their loved one passes away. And in terms of Ramona brought up anxiety, that's a real thing. And how do we support family after that journey with pancreatic cancer, whether it be the person with pancreatic cancer, or their family, moving forward, whether that outcome was good, whether that outcome was bad. But yeah, and I think the emphasis there on that that provincial meeting was really, hey, this is in Newfoundland. This is what a treatment journey should look like. This is what it's looking like right now. So of course, I just went over the concerns that we raised, and then as well, some of the potential solutions. That policy brief really will be going to the provincial government. We hope to have that set by Sunday. Of course, any updates that we receive, we will continue to talk to you guys, post updates on that. I think it's important really for everybody to be involved in the discussion. I think it's important for us to be clear as an organization. These are the concerns that we put forth, and this is what was said, and this was what was committed to. So really, we can not only ourselves be accountable as an organization, but really also government to ensure transparency. And my takeaway from that is that it was a great conversation. I think, our concerns were definitely listened to. I think they need to be actioned on. I think there's small actions that we can make now, and there are larger long-term solutions that do need to be developed as well. Again, I'm kind of getting ahead of myself there. I really hope that moving forward, we continue to have engagement with it. So, thank you very much for tuning into this. If you have any questions or concerns, please feel free to comment underneath below there, and we'll get in touch.